going to go back through contrast and density, and then next week we'll talk about geometric factors. So this is really more or less about to a degree patient factors, computer algorithm, contrast density, how to visualize it, how to clean up scatter radiation, that sort of thing. So again, largely review, and anytime you change anything, it kind of messes up your things. So we can make those a little larger. So what we'll talk about is the effects of MA, time, KVP, machine phase, filtration, body size, thickness, really, so body habitus, atomic number, SID, OID, grid use, and image receptor speed. Now, I understand that some of those things don't really affect it, so, it's just that we're being comprehensive and talking about all those things. Like SID doesn't affect, contrast does affect density, right? Or the density in context of image receptor exposure doesn't really affect density. So it's a short slideshow, so it's 26 slides, which is good. I've got an advisory committee meeting today, so department heads of the hospitals where we do clinicals, you may see them on campus if you stick around long enough. You'll also see clinical instructors as well, as Amy's doing a clinical instructor workshop, so we run both of those on the same day. So control of exposure, determined by the number of photons. What controls our number of photons? Mass, right? So anytime that we have insufficient photons or too many photons, providing we have enough penetration, your answer to insufficient exposure is always going to be your compensation for almost everything, with the exception of something that you need to penetrate at a greater degree, is always going to be mass, right? So I think I've said this, probably beaten it to death, but I do really believe that at some point in your career, we're going to make a switch over, and KVP is going to be your controlling factor of all of that, because it lowers patient dose. It's easier on the X-ray tube. There's just, and since it doesn't really control contrast anymore, there's almost no reason to use mass. But the industry hadn't really caught up with the technology yet. I expect it will eventually, and at that point you'll have to make a change, and no longer will you be compensating for patient thickness with KVP, or with mass rather, maybe not even grid use. With mass, it'll be KVP. It just hadn't gotten there yet. So it determines quality of photons. That's going to be your mass. So the controlling factor is going to be mass. Influencing factors would be the other things, specifically KVP would influence your exposure, SID, OID. Let's just run through them real quick, and I'll shorten the rest of them. MA and time, of course, is your mass, and that would be your controlling factor of image receptor exposure. So KVP, if you had a chance to review the three-part series I did last year on KVP, this should sound familiar. I mean, it's 2.5 hours long worth of nothing but KVP, but it's pretty comprehensive. So KVP, you know that it's the most significant factor. It controls your exposure more than anything else. But we call it an influencing factor because as of yet, it's not what we use to control image receptor exposure. So it's an influencing factor. It's a secondary factor. We still use mass to control exposure, and it's still testable. And they just changed the registry, so it's not, or they're in the process of changing the registry. So, and that's not changing. Mass is still your controlling factor of image receptor exposure. But just know that KVP controls it more than what mass does, but we call it influencing because it's not a direct control. Machine phase, three-phase, gives us a greater image receptor exposure than single phase by a factor of 2. Exactly. All right. That takes a while, and it's so confusing. If we go, to high frequency, it's a factor of 2.5. But it's kind of fun in the first semester when we go through that. Students are starting to feel kind of confident, and sometimes I got a mean streak, right? And sometimes I say, okay, you go from a single phase to a 3-phase, how much of a change do you expect that you would have? And somebody will immediately and logically bark out a factor of 3, and I'll go, eh. I'm never answering another question.
Yeah.
So I had a couple of people shut down from that, so I kind of So single phase, 3-phase, we get double the output. 3-phase, single phase, we get half the output. So our technical factor of choice there would be, again, mass. Filtration, as filtration increases, remember it's kind of complicated. It behaves a lot like a change in machine phase or KVP in that it pushes everything to the high energy side, but it lowers the height. So we get a decrease in photons emitted from the X-ray tubes, or what we do to compensate for that reduction would be increase your mass. So field size, if we increase collimation, we decrease the amount of scatter that's going to be created. That scatter lays down a layer of fog, right? Lays down a layer of fog. So if we increase our collimation, make our field size smaller, then we reduce the amount of fog that we create, and therefore our intensity at the image receptor is reduced, and we compensate for that by changing our mass. Exactly. So atomic number, this is where it gets a little bit dicey, and this is where we may have to go with KVP. So if you have, and realistically in the densities that we normally deal with in human tissue, you know, you could change your mass, you know, because 70 kVp you're going to penetrate any bone in the body, but it's not best practice. So there are times we want to change our KVP, and those will be those times. If we have an increase in bone density, we might want to increase KVP. If we have a decrease in bone density, we might want to decrease KVP. So that's where we have the osteoporosis. We want to decrease KVP potentially. And if we have petrosis, osteopetrosis, we will want to increase KVP. And the purpose for that, especially with the osteopetrosis, would be that we wouldn't be increasing patient dose, right? As much, anyway. With body habitus, again, the science says that the thicker the tissue, the more scatter you're going to create, right? So you go from somebody who's asthenic to somebody who's really hypersthenic, or if you go from, I don't know, a foot to a hip, you're going to create significantly more scatter radiation, so you need a grid, right? So let's go with like exams. You know, your KUB on a asthenic patient, you're not going to need quite as much. If you go with KUB on a hypersthenic patient, you're going to need more mass. Thank you. Right. So you're seeing a theme here. And the science behind the reason why we use mass instead of KVP is still valid. If we increase our KVP, we have an exponential increase in scatter radiation. And before we had digital processing, that there was a direct correlation to the contrast that we saw in the image, and we just don't see that so much anymore. We do see a change in contrast because of the soft tissue, right? Because of the increase in size. But if we were to use a higher versus a lower KVP, we just don't see that all that much anymore. So again, this would be something that's that the technology is there. It's just the theory and the practice behind using that technology has not caught up yet. So SID, as we increase SID, what happens to our image receptor exposure? It decreases, right? By how much? 3.24 if we go from 40 to 72. So square the change in the distance. So we need to compensate for that by using higher mass, right? OID, with the increase in OID, and this is something that a lot of times, even this late in the program, students have a hard time connecting the dots, right? So OID, you kind of got locked in, increase in OID, I need to increase SID, right? which is true to minimize magnification and to make sure that you don't have lost sharpness of recorded detail. But you do lose some photons just with an increase in OID, right? So if your SID remains constant and you increase your OID, you're going to lose some photons because of that wide angle scatter radiation. You're not going to lose any that are created or emitted. You're going to lose some that strike the image receptor, and we call that the air gap technique. Exactly. So how we compensate for that is with mass, right? So grid use, if you remember in Bushong, let's see if I can find this real quick. This is, I actually brought y'all's edition this time, 12th edition. If you remember in our, here we go, our grid, or our Bucky factors, what we would see is, this is on page 302 if you wanted to look it up later, but our Bucky factor changes with changes in KVP. So we'll get to that in a second. For now, though, if you introduce a grid, it absorbs scatter radiation. That scatter radiation would give you some exposure to the image receptor, and if you remove that exposure, you have to replace it with mass. Exactly. And the thing with KVP is that, you know, with increased KVP, we don't create more scatter radiation, so to speak, as much as what we emit more radiation from the patient, right? Again, you know, you can go back to that three-part series on KVP or previous lectures and see that. But we emit more of the scatter that we create inside of the patient, right? So remember, as KVP goes up, all interactions actually go down, but the percentage of scatter compared to photoelectric increases. Right, so the thing with KVP and grid use is that because scatter or grids absorb scatter radiation and KVP emits more, causes you to emit more scatter radiation, then as KVP goes up, the grids have more scatter to absorb, and then therefore they become more efficient. So the table on page 302, table 22.2, says this, that let's just pick one, we'll go with 12 to 1. At 70 kVp, your Bucky factor is 3.5. At 90 kVp, it's 4. At 120 kVp, it's 5. So that's your mass compensation at different kVp levels for that ratio of a grid. So the reason the Bucky factor goes up is because more of the photons that are emitted from the patient are scattered, and therefore there's more scatter to absorb. The grid indeed absorbs more scatter radiation, and therefore we need to replace those with a higher mass value. And then image receptor speed is not really, this is really something that should come off the registry as well. You don't really have a change in image receptor speeds in a hospital anymore. We used to have, you know, different speeds of screens of films, but if you're dealing with changes in image receptor speeds, then really what you're dealing with is different technologies essentially, right? So if you have CR and DR living in the same hospital, CR relative speed is 200, DR is 400, and therefore DR needs half as much mass as what CR does. So if you shot the perfect technique in a DR room, and then you mispositioned the patient, right, and you had to repeat it, and you took them over to the CR room, then you would have to change your mass by a factor of 2, right? So you just don't see that anymore unless you're dealing with, again, different technologies. So that's all those things. So those, again, mass is the determining factor, the controlling factor of image receptor exposure. All of those other things are the influencing. So the relationship to radiographic density, unless you really screw something up, there isn't much, right? So if you shot a KUB on a grossly hypersthenic patient with 4 mass, what are you going to get at the image receptor? Not much, right? So your image is going to come out pretty clear. On the flip side, if you shot a very emaciated asthenic patient With 400 mass, what are you going to get?
Black.
What's that?
Just a black.
That is exactly. So your image receptors, you can kind of think of them as individual little bitty cups of water, right? So, you know, you pour, let's say you set something over the top of all those cups of water, and you pour, you know, just a pitcher, put it in the shower, let's say. So it's got a, you know, sprinkling effect. Then where those cups of water are blocked, or at least partially blocked, they're not going to fill up as quickly as the ones where there's nothing, right? But if you leave the shower on long enough, what's going to happen to all the cups? They fill all the way up, right? So that's what's going to happen if you flood your image receptors with way too much radiation. So you really got to mess something up for, you know, underexposure or overexposure to really affect your density. So in those extremes, yeah, it can affect your density, and also in that way it can affect your contrast. But for the most part, if you shoot within a logical range of kVp and mass, it's really not going to have an effect on either contrast or density to a very great degree. So density defined, remember we have two different types of density. We have patient density and radiographic density. And patient density refers to a couple of things. One is truly density, and that would be your atomic number of the absorber. And you're going to see that referred to as Zeph number or Z number because it's not just straight atomic number. What's the atomic number of fat? Where does that fall on the elemental table?
Pretty low.
Well, just fat.
Okay.
Right, is
Is
just
that
not.
include
Is,
everything?
yeah. So it's got to include everything that goes into that fat, right? So that's the Z effective. Zeph means Z effective. That's the effective atomic number of the tissue. Even bone, you think of bone, you think of calcium, exactly. You think of calcium, but is that the only thing that's in bone? No, you got minerals of all kinds in there. You got zinc and all kinds of stuff in there. So it's a Z effective. So if you get to the registry and it says atomic number, just know that it's talking about Zeph number. If it says Zeph, then you know what that means as well. So where we have an increase in atomic number, or effective atomic number, we have a decrease. You know, we have an increase in patient density, we're going to have a decrease in radiographic density. So radiographic density is how light the image is. Patient density is how much the X-ray beam is going to absorb, right? So the things that can affect patient density and therefore overall density on the image receptor is certainly the atomic number, but also, you know, the thickness of the patient. So, you know, back to the KUB example, if you were to shoot an image where you grossly underestimated the mass value that you should have, then naturally your image receptor exposure is going to decrease. Probably more than seeing a decrease in the actual density on the image receptor, you're going to definitely see your index number change to reflect that underexposure, but you potentially could introduce some quantum model there. So radiographic density is just the darkness of the image. So MA, this is going all the way back to the first semester, controls the heating of the filament. Remember, we've got a filament circuit that's separate from the main circuit, right? And its only existence is to heat that filament up. And when we heat that filament up, we're just running amperage through the filament. It's not even milliamperage, it's amperage that we run through the filament. We don't get mass until we hit the exposure and we send the electrons across the tube, right? So MA just controls the heating of the filament, controls the space charge, controls the number of electrons that we're going to put into that space charge, and then that directly controls the number of electrons we're going to send across the tube. So once we hit the exposure, then we've got mass and we've got tube current. But before we hit the exposure switch, or we press the button all the way down, all the way through the prep button, then until we do that, we just have filament current. We don't have tube current yet. All right, so let's park on this for just a second. And I know we're going to talk about it later on. But we're right here in the freshman class, so some of the things that you know, that I'll talk about in freshman class, we haven't talked about in this class. So the space charge, remember, if you over prep, right, you hold the prep button down long enough, what do you get? Blooming is space charge. Also, if you use a very high MA station, you can also get blooming as space charge. What controls your space charge? And the stream of electrons go across, keeps them compressed. The cup, focusing cup, exactly. It's a focusing cup. So it's got a negative charge, it's like 25 kVp or something like that. Keep them compressed so that they at least leave the filament, you know, packed together like a bag of leaves, you know. Once they escape the focusing cup, they're going to spread out a little bit, but the focusing cup, purpose for the focusing cup is to kind of keep them somewhat compressed. That focusing cup can fail. So let's say, you know, you got a tube that's clicking along real good, real well, right? And you walk into the room one day and you make exposure and it comes up and it's like, this is just garbage. So you repeat it and it says, yep, this is garbage again. And every exam that you shoot in there, everything is fuzzy. Then likely what happened is you lost your charge at the focusing cup. It's going to be more dramatic and immediate than something like you know, warping of the anode or anything on the anode that potentially could cause a loss of sharpness or recorded detail. Okay, so you're going to have telltale indicators that you've got things wrong in your X-ray tube. And for the most part, we've focused on those things on the anode end of the X-ray tube, the burning out of the bearings, right? Cracking of the anode if we big exposure on a cold anode. But there are things on the cathode end of the X-ray tube too that can happen. Let's say you can have an open filament. You try to make an exposure and a machine won't let you make an exposure. Open filament just means burnout. So you can have one filament that's burnt out and one filament that still works. In that case, you can still make an exposure just on one filament. So how you can test that is, let's say, you know, your tubes are exposure limited on small filament. So let's say you try to set 300 MA on small filament, it's going to give you tube overload. You can't make the exposure. But if you drop it down to 200 MA, it'll let you make the exposure. So let's say you make you set 200 MA at 0.1 seconds, you make an exposure and it allows you to, you set the same technique on a large filament, you can make a large exposure on a large filament, any MA station. But let's say you set large MA and it gives you tube overload light immediately. Then what that indicates is you've got to burn out large filament. It usually goes the other way around. You may burn out small filament before large filament. I don't know. But anyway, so quality control concerns, tube without change, tube output changes over time. What causes that?
Inherent filtration.
Increased inherent filtration caused by vaporization of the filament coating the inside of the X-ray tube, and we call that tanning. There we go, tanning. Right, so our QA for that is every year our physicist will come in and make an exposure and measure the amount of output from the X-ray tube. That's that linearity, right? So they'll measure and it's really deeper than that, it's overall mass, but they'll measure the mass, they'll set the mass, they'll find out exactly how much radiation is coming out of the X-ray tube. And if it's too low, it's not within those limits that we need it to be within, then they'll go in and they'll tweak the machine and bring it back up to where it should be. And that's because of tanning of the tube. We get an increase in inherent filtration, and the next year they'll have to do the same thing, and then every subsequent year after that they'll have to do the same thing again. So it's tanning of the tube. It's caused by heat. The tests, of course, will be linearity, and the linearity between rooms, again, is just referred to as MR to MAS output. That doesn't really have a place in this single tube example. Is just worth mentioning. So focal spot selection. So when we have focal spot, we change focal spots. This was on last test. We change focal spots. We should not see a reduction in output from the x-ray tube as long as our x-ray tube is working properly. I've worked with machines that you actually did see a difference between large and small focal spot, but that's because the machine was messed up, right? But if, 100 mass is 100 mass, 50 mass is 50 mass, 75 kVp is 75 kVp, and 100 kVp is 100 kVp. So if you have the same technique, if your machine will allow you to shoot the technique on either focal spot, you should get the same identical output from it. So, focal spot selection is going to be limited by the MA station primarily, but overall mass as well. If you try to set 200 MA at 6 seconds, it probably would give you tube overload there as well. So what's reciprocity? Give and take, right. So where do we apply reciprocity? MA in time, right? So how can we use reciprocity to our advantage?
Motion.
What about motion?
Like
Limit motion, or say again?
Decrease time?
That's limiting motion. Take it in the opposite direction. Breathing technique, right? If we want to increase time, give us breathing technique. So mass is all reciprocity is. So again, linearity, if we set a technique at, any given mass value with different MA and time stations, we should reasonably expect to get a similar exposure. So selection for breathing techniques, selection for, your limiting time. Unfortunately, with breathing techniques, sometimes in order to get the exposure time that you want to get, you may have to drop back to the small focal spot. For example, you're doing a sternum. The sternum is not all that thick, right? So in order to get a long exposure time, what you may have to do is decrease your KVP, unfortunate for the patient, decrease your MA and increase your exposure time. But you may have to dip that MA below 200 MA. So there's that. And then with mass timers, where do you see mass timers? This is digging way back. I hadn't mentioned mass timers in a year and a half. Jeopardy's not even a show anymore, is it? Portables, very good. Portables, right. So with portables, what you have is a fixed MA station. So when you're adjusting your mass, what you're adjusting is your time. So it's a 100 MA station, so you're actually adjusting time. So how do you shoot a breathing technique for a portable lateral T-spine? What you gonna do?
Take them to the room.
If at all possible, yes. Yeah. Yeah. But what can you do?
Bump up your timer.
Okay, you can increase your time, but what if, let's say you need let's say again you've got an asthenic patient, and all you need is a really asthenic patient. All you need is 50 mass. How long exposure are you going to have with 50 mass if you've got a 100 MA station?
0.2 or
It's
2.
only a half-second exposure. Is that going to give you a good breathing technique?
Reduce your KVP.
What's that?
You reduce your KVP.
Right, you would have to reduce your KVP. And that is going to give us dose considerations, right? I mean, there's only so much KVP you want to reduce before you get to a point where it's like, this is not good for the patient. So what you could do is reduce your KVP, not so low that you're shooting like a, ankle technique, but also do kind of a limited breathing technique. Have a patient take in a big deep breath and slowly blow it all the way out and make your exposure halfway through the exposure, right? So mass timers can be a little dicey in, you know, getting your breathing techniques? Okay, so we already talked about one of these, but the other one is, what if, again, you walk into the patient's room, and we hadn't talked about this, I think, since first semester physics. Let's say you walk into a room with a specific patient. It's your last patient of the day. You made an exposure, you phototimed, you made an exposure on the patient. Let's say you didn't phototime. I'll get to phototiming in a second. You make an exposure on the patient, you set a technique. Let's say you set a technique of KUB, maybe 80 at 32 mass. Okay, index number was perfect. First patient of the day is follow up on that patient. You bring them back down, you make an exposure on that patient, and your index number shows that the exposure at the image receptor was exactly half of what it should be. If it's exactly half, what could that be? This is digging deep.
Distance? Like distance?
Distance, let's say you use same distance. So everything you did was exactly like you did it the day before. Okay, so think hard. What things exactly double or half your, let's say double your tube output? It's the same phase of machine, so you're using the same room, so it's not single phase, three phase, but it's along those same lines. Say again?
Generator?
The generator specifically. One more time.
The rectifiers?
You're on it. The voltage ripple. Okay, let's say for this hypothetical situation, we're using single phase, right? You're not going to be using single phase, but this is easier to walk through. You're using single phase, right? So all of a sudden, half of those pulses are gone. Did you say it?
Yeah.
Rectifiers. You blew your rectifiers. Exactly. Yeah. So if suddenly you have a machine that it, you know, is immediately shooting at half of the expected value, then you've got blown rectifiers. Okay, so what if you phototime it? How do phototimers work?
They stop when you have enough.
They stop whenever they get enough radiation, right? So you make your exposure, they detect the radiation, send a signal over to the timer circuit to kill exposure, right? So what's going to happen if you phototime?
It's going to be a long exposure.
Going to give more exposure, exactly. Instead of being half the exposure, you're going to get twice the time, right? So either one of those two things can happen with your rectifiers. All right, so time in density or exposure, you know, is half a mass. Time in reciprocity, as we increase KBP or increase MA, decrease time, we arrive at the same mass. So imaging implications: do we want to limit motion? Do we want a breathing technique? You know, what is it we're looking for? Timer types, probably the only two timer types that you're going to see on the registry are either going to be synchronous. Remember, synchronous, they can only be used with single phase machines because with the overlapping pulses, you can't count the dots. And that's another thing that really should come off the registry because nobody uses single phase machines anymore. I don't even know if they make them anymore. But the other thing, the other top timer is your electronic timer. And your electronic timer, two things that they'll come at you for that is, one, it's most accurate, and two, it enables the shortest exposure time. So when we make an exposure, there's two words. You push the button to make the exposure, and they call that interrogation time. Okay, so it's the time difference between when you mash the button and the exposure actually starts. So going back to the single phase and the synchronous timers, you know, if your pulse is here and you start your exposure here, but the little generator in there doesn't let you begin the exposure till over here, then there's going to be a very, very short pause, it's imperceptible to you, but there's going to be a very short pause. So it's going to be a longer interrogation time compared to an electronic time where you mash the button and you get immediate exposure. Okay. Also, though, remember that at shorter exposure times, you get more erratic exposures as well. So, quality control implications, of course, you got to do quality control every year. So, SID. So it affects exposure inversely. That's why we call it inverse square law. As we increase our SID, we decrease our exposure. Our detents have to be accurate, right? And our distance indicators also have to be accurate. You got the tape measure on the machine, you got the detents. They should be in set places and they shouldn't move. So light field, we've got a couple of things on the light field. We've got the mirror. Remember, the light is offset. So if you look up into your collimator housing, what you actually see is the mirror, right? You don't see the light bulb. The light bulb's off to the side. So two things about the mirror: it's got to be at a perfect 45-degree angle, and if it's not, then it's going to project the light field somewhere aside from where the radiation field's going to be, right? So 45-degree angle, and the distance between the focus and the mirror has to be identical to the distance between the light bulb and the mirror, so that the divergence of both, are the same. So, we've got centering indicator and collimator, collimator accuracy. Collimator accuracy has got to be within 2% of SID, and centering indicator, perpendicularity has to be within 2% or 2 degrees. That's your vertical beam alignment. Usually done with the collimator quality control. So we're not going to have really any density issues unless it's really bad and we have an angulation that's so steep that it would cause grid cutoff. Otherwise, you're just not going to see that all that much. You may have some problems with parallax and the distortion of the anatomy that's directly in your crosshairs. Okay, so beam quality. Remember, our best measure of beam quality is half value layer. It truly measures, you can have two machines shooting with the exact same KVP, but one has more, you can't really say output, but a higher average KVP, right? And that happens again because of tanning of the tube. We get tanning, and the tanning increases our inherent filtration. We have to adjust things to get us to the same output. But what happens as we increase our filtration? It goes to the high energy side, right? It decreases the numbers, but because we're going to decrease in output, in our quality control, we're going to bring that output back up. So we get the same output, we've just got more of the high energy side, right? So, we do the half value layer test. We measure KVP, and that's just with digital KVP meters. We used to have, we still have around here, we've got a cassette over there somewhere. You don't have to pull it out. But anyway, it's what we refer to as the Wisconsin test cassette. And what it had in it was a step wedge and a number of filters and things, and we could make an exposure on it, and it could detect a change in KVP of, I think it was 4% or better, which put us, about half of where we needed to be, as far as KVP goes. So we could measure KVP value with the Wisconsin test cassette, but it didn't use anymore. Okay, so density in CR and DR is not density. It's exposure as represented by our index number. So penetration is still important. Penetration is your KVP, and exposure is still important. We still have to have our exposure within a reasonable range of on our index number. So remember, we've got 2 histograms working. The lookup table is a stored histogram inside of the computer. So it's the ideal image. And we didn't do it when we put this new machine in. But in, every other time I've had a new machine put in, the applications tech would come along and they'd have maybe, for every exam, they'd have maybe 4 different x-rays on the screen. They'd say, okay, which one do you like best? And what they do is they take usually 1 or 2 radiologists, maybe a super user or whatever, and possibly a technologist. Really, the radiologist is the most important person in that room looking at those images. And they take a look at the images and they say, okay, I like that one best. And the applications person would select that, let's say it's a hand, that image of the hand, and that would become the hand by which all other hands will be compared to, right? So have y'all seen histogram? Histogram is just a bunch of not squiggly, but straight lines. It's just on a graph that's, kind of long, and it's got these vertical lines and then gaps in between them. There's some in the Bushong book. You just told on yourself. Some in the Bushong book, but what the automatic rescaling does is it takes those lines and you feed it your histogram. The histogram is your representation, as it's those squiggly or those pointed lines. And if your histogram has lines that are spread out like that, and the stored one has lines that are like that, what the computer does is it takes and it goes like this so that your contrast and density looks like the one in the computer. It looks ideal. That's why you take an image of somebody's hand and it looks, aside from pathology, like every other hand that you ever shoot, right? It takes care of all of that for you. So that's automatic rescaling. Where you have problems with CR processing is if you do things that the computer can't make sense of. With CR, it was collimation. If you collimate in such a way that you don't collimate at all, or if it couldn't recognize your lines collimation, then it would throw it into histogram analysis error. We still have that with DR, but it's more of, if you miss position or if you don't collimate on anatomy that you really should collimate on. You put an elbow on a 17 by 17. What you're going to get is a lot of direct exposure to the image receptor. And it takes all that into consideration whenever it's trying to match up the algorithms, and it can't figure out what you did. Why do you have all this overexposure when it should look like this? Reasonably look something like this, right? So that's your automatic rescaling histogram lookup table. Histogram is what you shoot. Lookup table is a stored histogram by which your histogram is going to be compared and adjusted to. In post-processing, you have leveling and windowing, level and width. So that is, if you're wanting to take a look at different, you want to try to bring out the contrast in something, you can adjust that, push the buttons. Just make sure that you save the original. Once you make that post-processing effort and you save that and you send it, if you don't have the original, the radiologist can't undo what you did, right? You have to keep in mind that your computer monitor is not the same as his or her reading monitor. They're very high definition, as opposed to ours are, basic computers. So what looks good on your computer might not look good on theirs, right? And vice versa. What doesn't look good on yours may be perfect on theirs. So what we have a tendency to do is look at the image. Yeah, that looks good, that doesn't look good. Look at the index number is good, but the image doesn't look good. Well, what are you gonna do? You gotta evaluate everything else. Why does the index number look good? Does it look good because you didn't collimate and you got a lot of overexposure, in which case your index number is in error, right? It's telling you you got a good exposure when in fact you did not, right? But if you did everything just right, you know, if you got your collimation right, you shot with the right technique, your index number is right, and your image still doesn't look good, it may be because you got a crappy monitor. In which case you don't need to be adjusting the contrast and density and sending that image. You can, but make sure you send the original too. Because what you might do is adjust the contrast and density to look good to you, and once it goes to the radiologist, it looks awful. So acceptance testing, that's a new machine. That's just a check off. You know, you get a new machine, a physicist comes in and makes sure that there's no leakage in the room. They make sure that the KVP, the mass, focal spots, you know, they run all the QA tests, and they just make sure that everything is shooting properly. And then you sign off on it. You say, yeah, you know, I'll accept it as is. Or if something's not right, then you tell them, you know, you got to fix this. So, and then the other ones we've already talked about: reproducibility, AECs, image receptors, tomo, fluoro. Tomo is really not a thing anymore. It's off of the registry. It should come out of PowerPoints. I'm going to get back to my office, and I'm going to not remember to do that. So we're going to do that here. These slides should be in Canvas, and you should be able to see all of this down here, which is just notes on all that stuff. Okay, there we go. So, pathologies that can change your contrast and density or exposure. Remember, we've got additive or destructive pathologies. So with any kind of additive pathology, that's adding tissue density essentially. So we have to increase something. Could be KVP, most of the time it's going to be mass. Your default setting should be, if you get to a test and you can't remember, you don't know, you know, KVP or mass, go with mass, all right? You know, if it's bone, okay, KVP, but if you're just kind of, you know, it could go either way, go with mass, because 90% of your changes are going to be mass. So just running through some of these and definitions. Atelectasis, what does that mean? Collapse of lung, right. What's the difference between atelectasis and pneumothorax? Yeah, you got air in the pleural cavity with pneumothorax, and that's causing the collapse of the lung. So you got two things going on there. But can you have atelectasis without a pleural effusion? Oh, shit. I just gave it away. Without a pneumothorax?
Pleural effusion.
How did you know? Yeah. Geez. Okay. All right, so cancer. Anybody seen a bad, like, chest cancer? Lung cancer? Yeah. It's,
I think it was cotton balls.
yeah, yep. It's kind of subtle. It's kind of like you took cotton balls and you dipped it in just the slightest amount of barium or milk or something. You just put it, you know, put little dots on the screen. So it's an increase in patient density, but it's pretty subtle, unless it's really bad. It's pretty subtle, you know, so does it really need that much of a change in technique? And I'd say probably not. Bone cancer goes the other way though. So bone cancer, you've got eating away of the cortex of the bone. Bone cysts look like bone cancer, but you can still see the cortex. Okay, so you shoot an image on somebody and you might even have some deformation in the bone, but if you can still see a semi-well-defined cortex, then chances are that's bone cyst. And the demographics on bone cysts are long bones in young people, say, you know, 30 and under, and usually more often than not, females. Okay, so but if if you've got that moth-eaten appearance of the cortex, that's something much worse. A bone cyst they can fix that. So aneurysm, again, most of the places we're going to see an aneurysm, or the most common place we're going to see an aneurysm, is in the abdomen. And the most common time that we're going to see that is not when we're looking for an aneurysm or even any kind of belly issues. It's going to be a lateral L-spine. An indication the patient has an aneurysm in that case would be presence of calcium just anterior to the vertebral column. Really don't need a change in technique for that either, because we have soft tissue on soft tissue, and then we've got little bitty calcium flakes that really aren't going to change a whole lot in the appearance on the image. You're just going to see them. The worst aneurysm I ever saw, it was still, soft tissue on soft tissue, but we were getting ready to do an IVP. Are they starting to do IVPs again? Anywhere? No? Okay. I'll hold my opinion on that. But anyway, we were doing a scout on this patient, and once in a while, you may have seen this. You'll see an x-ray. As soon as it comes up, you're like, I can't be seeing what I think I'm seeing, Had a guy with a spontaneous pneumothorax one time. He just came in, he said, I can't breathe, and I got chest pain. His entire lung was about the size of this dry erase marker. He coughed. So demographics on that is generally tall, thin men. He coughed and his lung went down to nothing. And in this case, we shot the scalp before we were doing an IVP on the patient, and you've got the spine, and then we saw a bulge on either side of the spine. And it's like, okay, don't inject this patient. It was when I was still a clinical instructor at ETMC. Don't inject this patient, don't move this patient. I want you to go back and show this to the radiologist. So I was like, this can't be what I think it is. And sure enough, it was a AAA. That guy was on the operating room table at the other hospital the next morning. Dr. Abernathy was a radiologist, a great radiologist. Actually, one you can work with pretty well. It's rare. But at any rate, yeah, he took him back to CT, and he personally did the injection over, and it was a limited injection. It was just one thing ICU, and he took about a minute to inject it. He said if we'd have injected that patient with 100 cc's, it'd have gone on the table. He would have been dead in 6 seconds. So massive aneurysm. Did we need a different technique for it? No, it's soft tissue on soft tissue, right? So pleural effusion though, what's that? Well, it's cause for atelectasis. What is it? Fluid where air should be, right? So now we're going to need a change in technique. Now we've got fluid where air should be, and our technique change should be mass. There you go. It's mass. I will say this though, pleural effusion. The whole thing about chest X-rays, you don't need a grid because of a natural air gap technique, right? Is natural air gap. Natural, whatever. You got two structures full of air is what you've really got there, right? We took a decubitus chest on a patient with massive pleural effusion, and we could see absence of lung, but we couldn't see where the pleural effusion ended. And then we went back and we shot it with a grid. It's one of the most stark examples of what a grid can do for you that I ever saw personally. So we went back and we shot it with a grid, and it cleaned up enough scatter radiation you could see exactly how full that lung was. Okay, so a couple of things with pleural effusion. So you're going to have to increase your mass, and number two, a grid becomes important even if you wouldn't normally use a grid on that patient for a chest X-ray. It becomes much more important. The cyst, well, what is it? Is it a bone cyst? Is it a cyst in the lungs? Is it an abdominal cyst? If it's an abdominal cyst, probably no change. bony cyst, you may need to decrease a little bit. If it's a cyst in the lungs, you may need to increase. It's going to look a little like either a hiatal hernia or a pleural effusion, just kind of localized, right? So hiatal hernia, I just kind of gave away. Emphysema, what we have there. Patient comes to you wheezing and they're on oxygen. What's that?
Nothing, isn't that the one where they're like barrel chested?
A lot of cases are barrel chested. The bottom of the diaphragm is flattened, right? So one thing that you ought to consider if you have a patient like that is if you have a rectangular shaped image receptor and providing the patient's not hypersthenic, you might consider going lengthwise, because with emphysema, you know, we see the patient, they're on oxygen and they're wheezing, you immediately think the patient can't breathe in. You know, they're having a hard time getting air in. When in fact, what happens with emphysema is those alveolar sacs lose their elasticity and they're stuck open, okay? Think your old socks, okay? What happens when your socks get old if you don't wear a hole in the bottom? The elastic at the top doesn't grip onto your ankles or your calves anymore, right? Because they're stretched out, okay? Emphysema, they're stuck open. They're not having a hard time getting air in, they're having a hard time getting air out. I can't even imagine how miserable that would be. You know, you have to force carbon dioxide out so that you can get oxygen in, right? I think I have a hard time sleeping at night now. I can't imagine that. So if we have hyperinflation of the alveolar sacs, then naturally the patient density decreases. So then what we have to do is decrease our technique. And cardiomegaly, large heart, we would have to increase. So in the abdomen, bowel obstruction, what are your telltale signs of bowel obstruction? You walk into the patient's room for a KUV, you're doing it portable because you can't bring them to the apartment. They won't let you bring them to the apartment. You walk in, what are your telltale signs the patient's got a bowel obstruction? Well, first, the chart should tell you. Secondly, the nurse should tell you. But if you can't find either one of those, what are you looking for? They got a great big distended abdomen.
A lot of air.
Well, that is after you make the image, you can see all that air.
Yeah.
But what's the indication before you make the image? Because if you got that big old distended abdomen, are you increasing or are you decreasing technique? If it's air, you got to decrease. If it's not air, you would have to increase.
Yes. I mean, if they've been constipated.
Okay. Okay. If they've been constipated, maybe they hadn't had a bowel movement. But what if they're out of it? NG tube. Who said that? Okay, very good. NG tube. If they've got an NG tube, that NG tube is hooked up to a suction canister on the wall. That suction canister on the wall is full of bile. They got a bowel obstruction, right? So now you know. Another thing that you could do, and usually if they're edematous, if they're full of water, they're not just going to have a distended abdomen. They're going to be, they're going to be puffy all over, right? But just to be sure, what you could do is you could walk over and kind of, squeeze their ankle a little bit. And if they're full of water, if they're not full of water, you can squeeze your own. And as soon as you let go, what happens to your skin? Pops right back. But if they're full of water, it comes back like memory foam, right? You pinch it in a little bit and it just slowly, it doesn't spring back. So that would be an indication they're full of water. If they're full of water, you're going to have to increase your technique. If bowel obstruction, telltale signs of bowel obstruction, you got to decrease. So causes for bowel obstruction, you got a lot of different things. You got intussusception, you got volvulus, you got paralytic ileus. Paralytic ileus is probably not going to get to that point where you're going to be taking an x-ray on somebody with a big distended abdomen. Paralytic ileus will also be referred to as a non-obstruct ileus, meaning there's no mechanical obstruction. Maybe the patient had surgery
And if you've never had surgery, then, just be ready for this. They're not gonna let you go home until you fart, just to make sure that, things are going through. And they'll come in and they'll ask you over and over again. It's a little invasive, to be honest with you. So Crohn's disease, ulcerative colitis have kind of the same appearance. And that is, you've got that, cobblestone appearance of the bowel. Diverticulosis, diverticulitis. It is diverticulosis, it is. You're probably not going to see that unless you put contrast into the patient, or if it gets really bad, if the itis gets bad. And edema we already talked about. So bone diseases, casting material. Remember, if you've got fiberglass casting and it's dry, you don't have to do anything. If it's wet, you may have to increase your KBP by maybe 5 kbp. We already talked about osteopetrosis and porosis. We talked about bone cancer. Acromegaly follows osteopetrosis. That's, a great increase in bone. Paget's disease, arthritis, you've got two. You've got osteo and rheumatoid. And with osteoarthritis, you don't really have to increase your technique, but you will see an increase in density, patient density, decrease in radiographic density at the articular surfaces. Because of that constant irritation, bone on bone or whatever, those articular, starting to feel you, arthritis, yeah, those articular surfaces will be brighter, but you don't really have to change technique. Rheumatoid arthritis looks like osteoporosis, only worse, right? With osteoporosis, all the bone is there. It's just that the cortex is smaller, as opposed to rheumatoid arthritis. Those articular ends will just start to deteriorate. So body habitus, contrast media. Contrast media, I kind of split hairs on this. It's not really a patient density thing. It's just the presence of media. So remember, you've got positive and negative types of contrast. Barium and iodine. What you'll find in test questions sometimes is that be real specific about maybe not the specific atomic number of barium and iodine, but the two are very close. If you look at the elemental table, I don't remember exactly what they are, but they're very close. So why does barium show up so much better than iodine if atomic number is the thing that absorbs more X-rays?
Density? More dense?
So, okay, let's explore that a little bit.
Okay.
By that, what do you say?
More compact?
Bingo. It's in solution, okay? So think about your iodinated contrast for C spines versus L spines in milligrams. What's the difference between those two? Maybe ISOVU 200 versus ISOVU 300 or 400, right? So what they're going to do is, if they're doing a C spine, is that they might inject the one with a higher number, which is reflective of more iodine in the solution, so that when they tilt the patient up and it runs up into their neck and it mixes with all that CSF, there's still enough in suspension to get into the C-spine that they can make the diagnosis, okay? So carrying that out to barium, the quantity in solution is even much higher than either one of those, right? So you mix up barium, you've got that bag for an air contrast PE, and there's that much barium in the bottom of it. And then you put that much water in it, right? So you're 50% barium and 50% water. It's a lot, right? So it's just the amount in suspension. So atomic number wise, very close, or like within 2. It's just how much do you have within that, that quantity of liquid. Okay, so soft tissue images, we can bring out soft tissue in CR and DR, even if we're shooting for bone. So it's really not much of a thing anymore. Body habitus, we've done to death. Age, with age, we lose 2 things, One is the more dense soft tissues. So we lose musculature, and we also have a tendency to lose bone. Development, okay, so now we're getting into things like hypertrophy and hypotrophy, right? So hypertrophy is overdevelopment, right? So let's say you got somebody who does a lot of weight-bearing exercises. What are they going to build? Muscles. That's one, but what else do you get? Much stronger bones. Bones, right? So here's your, kind of your tip for the day, especially for the women in the room. Osteoporosis is a thing, right? And it's a thing that usually comes on you after menopause. So everybody's going to go through menopause. It's just a thing. And you're going to start losing some of that bony, bony mass. And once it starts, what happens is that it's not due to a lack of intake of calcium. In a lot of cases, what will happen is people say, well, I have osteoporosis, I'm in menopause, I'm going to start taking calcium. It does you no real good. Because what's happening is that you're losing bone faster than you're rebuilding it. So your best defense against osteoporosis postmenopausal is to go into menopause with very healthy bones, okay? So do those things beforehand so that they're not quite so bad afterwards. And pathologies, we just ran through a whole bunch of them. Contrast is really in filmed radiography is because it changed the differential absorption. As we increase our KVP, we get more penetration through all different types of tissue, but really now it's our computer algorithm. So contrast, just difference, patient radiographic, we already talked about. I think all of the rest of this stuff is redundant and things that we've already discussed. Any questions?